So welcome. Oh, thank you. So welcome to our Valentine's Day Echo. If this is your first time with us, we're so glad that you're joining and we'd love to meet you. So please put your name and where you're from in the chat. Unfortunately, Dr. Sabayan was called away on a family emergency. And so I'm going to be giving the didactic on protecting brain health, modifiable risk factors for dementia. There will be plenty of time for, I hope, a robust discussion. And so please rename yourself, first and last name, and where you're from. If you're not speaking, please mute your microphone, and then when you're speaking, unmute and say your name. If you can, turn your video on so we can, see one another in this virtual community. And if there's more than one person in your room, please put all the names in the chat. For University of Washington faculty, staff, and students, you can complete this mobile text registration and sign in for attendance and CME credit. You may have already registered, but if not, what you want to do is to send your UW email address to this number here, and you'll receive a response stating that your number has been updated. And if not, you can sign in to uwcme.org. And then after registration, you can just text this 10085 to that number, and it will track your participation and provide CME. All others, we are recording your attendance through Zoom Analytics, and Sammy is also tracking that. So in order for us to do that, we need to see your name, your full name, please. And if Sammy needs additional information, she can connect with you later. So we have a number of fantastic ECHO programs, including University of Washington Project ECHO Geriatrics, which meets on the third Friday of each month from 12 to 1:30. There's a UW Traumatic Brain Injury and Behavioral Health ECHO. There's a Psychiatry and Addiction ECHO, a Telementoring Health Training Series echoes. So just really a great range of different echoes to participate in. There's also a diabetes echo, and there's a telephone consultation for people who are on complex pain regimens, particularly high-dose opioids. That's the UW and Opioid Provider Consultation Hotline. You see the 1-844-520-PAIN number. There's also a CME accredited case conference series, the UW Telepain series as well. As well as grand rounds, both in psychiatry and neurology, which are available via Zoom and through an archive. So mentioning again this fantastic upcoming Dementia Innovation Summit, which is geared towards primary care, really centering primary care at the forefront. As you all know, and as you live in your daily clinics, primary care, you guys provide a crucial role in timely and accurate detection and diagnosis of dementia, management and support of individuals along their cognitive health journey. So please join us if you can for this day of insightful discussion, networking, practicing new skills, and earn 6.25 CME. So it's March 7th, 2025 at Valley Medical. You can scan the QR code here as you see, and here are some key topics, such as evaluation of cognition in primary care, brain health in practice, dementia as a team sport, and goals of care and advanced care planning, and so forth. So please, if you can, join us. We also are very pleased to share that we have our Community Healthy Aging Summit that is happening at Mercer Island Community and Event Center on April 18th from 10 to 3. And this features as the keynote Mary Grace Becker. And then this is really open to the community at large. So for people living with cognitive health challenges, their care partners, others who are interested, it's going to have a brain health lecture series as well as 3 interactive breakouts, one with seated dance class, a music therapy, and some brain games. And it's free to all, thanks to a generous philanthropic support. You can also scan this QR code if you're interested in attending. Okay. Cases are so key to the ECHO model, to this practice transformation that we're all engaged in together in this community. So please bring forth your cases. Please do bring them forth. Consider it, try it out, connect with Sammy. We can help you. No case is too simple or too complex. We can all learn together. Again, please bring your cases forward. Okay, so when you are bringing your cases forward, we never reveal any PHI. We protect public health information during these sessions, so don't display anything that could reveal any personal information. All of our ECHO sessions are recorded and available on the website, and then there will be this 1-minute post-session survey, which helps us to iterate and improve. There's CME accreditation, as you see here, for a maximum of 31.25 CMEs per year, or 1.25 per sesh. I have no financial disclosures, nor do any of the planners have to reveal. And if that is ever the case, we mitigate these financial relationships. In this case, there are none, as I said. Okay, so this is our hub team smiling at you. And we comprise a range of health systems and Dementia Action Collaborative. And so here we are together. And then you all, wow, look at this. I mean, we've provided over 1,700 instructional hours since June 2020. In 2023, 100% of respondents reported that Project ECHO Dementia improved their quality of care for patients with dementia. Nearly 64% reported changes by others within their organization. So this practice transformation is really spreading based upon that participation of the individual. So it's spreading kind of locally as well. Current community, 96 sites, serving 250 zip codes, over 243 providers. And if you are interested, please reach out directly to Samantha LaFontaine here, or you can look on the website and then sign up. So today we don't have a formal case presentation, but hopefully, as I said, we'll have a lively discussion after the didactic. Oh, that's okay. So I'm going to talk to you today about protecting brain health, modifiable risk factors for dementia. So let me stop this share and then do another share. Hold on here. Okay. Thank you. Let's see here. Okay. And then over here. 1 sec. Wait a minute. Sorry. Thanks for your patience. 1 second. Here we go. There we go. Okay. Are you seeing that? Oh, wait a minute. Just a minute. Stop that. Share. Okay. Okay, so you're seeing full screen protecting brain health? Yes? And I can't, can somebody, yes, I'm going to assume we are seeing that, correct?
Yes, we can see it.
Thank you for unmuting and saying that. Okay, great. So as I said, I have nothing to disclose. So the learning objectives for this talk are to identify 6 modifiable risk factors for dementia across the lifespan, to apply best practices in brain health and dementia risk reduction, to develop strategies to emphasize these overlapping risks for heart attack or heart disease, stroke, and dementia. And then how do we implement these risk reduction strategies in the clinic to support patients on their cognitive health journey? So brain health is defined as the state of brain functioning across cognitive, sensory, social, emotional, behavioral, and motor domains that really allows that person to realize their full potential across the life course, and really irrespective of the presence or absence of disease. So how can people thrive as best they can with the reality of their current challenges, and seen and understood through this interconnected social determinants of health. And this is the definition that the WHO put forth a couple of years ago. And brain health is really critical for, all aspects of our functioning in the world. I want to introduce this concept, which may be familiar to many of you, but the concept of neuroplasticity is so key when we're thinking about behavior change, and many of the modifiable risk factors that we're going to touch upon do involve behavior change. So thankfully, we humans are malleable and we're adaptable. If not, we wouldn't, survive in the world, right? And so resilience coping is something that we can cultivate and learn. And this is neuroplasticity. And what we do, what we think, what we pay attention to intentionally, and what we practice changes the structure and function in our brains. Okay. So there's different types of neuroplasticity. And this, of course, could be a whole talk in and of itself, or a whole, semester course. But really quickly, what neuroplasticity is the capacity of the brain to change and adapt. And we think of it in two basic categories. One is sort of that structural plasticity, which is that our experiences or our memories or what we practice changes the brain structure after a lot of repetition, after a lot of practice. And then there's functional neuroplasticity, which there's a lot of redundancy in the brain, meaning that functions can be and are subserved by different systems. And so, for example, if you have a stroke, that damaged area, that function may possibly be subserved by another area of the brain that is undamaged, and that is functional plasticity. So structural and functional plasticity are two different types of neuroplasticity or brain plasticity. Okay, so here's our first poll. What do you think is the most important modifiable risk factor to prevent or decrease the disease progression of dementia? And you can see the poll here, and there's no right answer. This is really just to engage us in a discussion. I mean, so please put in your answer. You can just put in a short answer. Oh, sorry, let me go back. Are you guys seeing the poll or?
Sorry, I just closed it. You should be able to see the answers now.
Okay, let me just stop sharing and share results. Do you see any results? It says 7 of 18% participated.
I can only see my own answer.
Yeah, I don't see. Sammy, are you seeing anything?
I can click on a link to see it. So why don't I share my screen really quickly so you guys can see those results?
Okay.
Yeah, I only see my answer too.
Okay.
What we had answered.
Let's see. Okay, so vascular health, nutrition, healthy diet, smoking, exercise, social engagement, optimization of medical conditions. Thank you. Yeah, so all really important answers. That's great. Okay, so let's continue with our talk. So yes, 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 and yes. Okay. So really, when we're thinking about a life course model and risk reduction, we've got to think of a multi-component approach. And it's not to say that we have to do everything all at once. We want to break things down to small steps, incremental change over time to set people up for success. And yet these approaches really are so interconnected. So there's a synergistic interaction with these multi-component approaches to really address dementia risk reduction. So We think of brain health and the connection to heart health, so really addressing and optimizing heart health. We talk about the importance of cognitive stimulation and social engagement, lifelong learning. We talk about movement as medicine, food as medicine, and then really how do we target other modifiable risk factors and sleep. And if you've slept well, then you're more motivated to exercise. And if you have a girlfriend that you enjoy walking with, the likelihood that you're gonna, so a social connection to that movement practice will enhance the probability that you're consistent with that. And all of these things have an impact over time to reduce your risk, which we'll talk about in more depth as talk proceeds. So this is the great graphic that came out in 2024 and initially in 2017. I'll just give you a little bit of background. The Lancet did its first commission analysis and found that 1 in 3 cases of dementia are preventable. Then in 2020, 40%, and now in and then last in 2024, 45% of dementias are preventable. I want you guys to throw in the chat, when you ask patients this question, when you pose that question to them, what percentage of dementia do you think is preventable over the lifespan? What are some of the answers that you've gotten? Or you could just even like unmute yourself and share. I'm really curious.
I haven't asked that question, but I'm going to add it.
I mean, in my case, for example, people have said 0. I don't think any dementia is preventable. Have you guys had that experience in your office?
I get a lot of questions from adult children bringing
Yes,
their parents in
right.
and asking about what can I do to reduce my risk.
What can I do to reduce my risk? Or is it even possible? Or am I going to be my parent? Is this what my future holds? Yeah, thank you for sharing that, Kimmy. So when we look at this most recent Lancet review, you'll see in early life, we know that lower education is a significant risk. In midlife, hearing loss, high LDL cholesterol, and we're going to talk about these in more depth, but I'm just going to go through them briefly here. Depression, traumatic brain injury, sedentarism, diabetes, smoking, hypertension, obesity, excessive alcohol. We'll define what that means. And then later, since people probably are wondering, and then later life, social isolation, air pollution, and vision loss. And were we to, at the population level, target these modifiable risk factors, we would be able to prevent 45% of dementia over time, which is huge. Okay, so here is looking at sort of the strength of the evidence, and the strength of the evidence for the role of formal education as being neuroprotective. The higher level of education, the greater cognitive reserve. This evidence is quite strong, both in terms of preventing cognitive decline and dementia. Traumatic brain injury, we'll talk about, we're not thinking about one concussion, but we're thinking of repeated and pretty high impact traumatic brain injury. The evidence is quite strong. In midlife and late life hypertension for cognitive decline, very strong evidence. For dementia, not as strong. And we'll talk about this, the Sprint Mind study. For midlife obesity, stronger for cognitive decline, diabetes, as you see here. I'm not going to go through all of these, but just to kind of rank the strength of the science. This is more kind of in an emerging science space. Here we go. And this is an illustration of the numerous mechanisms by which addressing these modifiable risk factors can prevent or delay the onset of dementia. So if we can reduce type 2 diabetes, for example, we could reduce vascular damage. We could reduce stroke risk. We could reduce the dementia, the misfolded protein aggregates, or the neurodegenerative changes that can occur. If we can reduce obesity, we can impact stress and inflammation. If we can treat and prevent depression, we can build this cognitive resilience and reserve. and so forth. So this just illustrates how these various, targeting these risk factors can impact on vascular damage, dementia neuropathology, stress, and neuroinflammation, and cognitive and brain reserve to all, prevent and delay dementia, which is the goal. This is a picture of the 6 pillars of lifestyle medicine, and I'll go through this pretty quickly, but these approaches helps to reduce, diabetes, cerebrovascular and cardiovascular disease, stroke, vascular cognitive impairment, and dementia. So the diets that have, the 3 common diets associated with cognitive and stroke protection really have reduced dementia if you adhere moderately well by about 30% and really well by about half. This is the MIND diet, which has been studied most extensively. We know that people who have chronic insomnia have a higher risk of developing dementia. If you have untreated sleep apnea, there's a higher risk of stroke, heart disease, dementia. Loneliness and social isolation increase your risk of stroke and dementia. Sorry, let me just go back. Physical inactivity, stress management. Stress is really strongly linked with higher risks of hypertension, stroke, cognitive impairment, and then substance use, which we'll talk a little bit about. So here now we're going to talk super briefly about the vascular factors. So hypertension is the most significant vascular risk factor of all, and 1 in 3 middle-aged adults have hypertension, and 1 in 2 it's predicted actually by now. So and we know that, there's shared risk factors for dementia and stroke, as well as I keep emphasizing, heart disease. So all of these risk factors, hypertension, diabetes, obesity, increase the risk and susceptibility for stroke. And stroke can increase your risk, of course, of vascular dementia, but also for Alzheimer's disease as well. And these are the changes that we could see in the brain contributing to this risk. So the Sprint Mind study found that this was a study that looked at more aggressive blood pressure management and intensive blood pressure management with a systolic blood pressure of less than 120 was found to reduce the onset of MCI, and also to slow the development of microvascular ischemic disease. However, it didn't, and also the rates of shrinkage in the brain, it was not found to prevent dementia. So there are ongoing studies, but I'm sure you see many people with midlife hypertension, and we can talk about how you help them to manage that. Okay. Additional benefits of aggressive management of this systolic blood pressure goal of less than 120. We're talking primarily more in midlife. Have decreased risk of acute MI, coronary syndrome, stroke, heart failure, and cardiovascular death. What about smoking? So we're going to do a poll in a moment, but when you do a very large meta-analysis, the risk is increased by 34% for every 20 cigarettes per day. And former smokers who stop, if they stopped, they didn't show an increased risk for all-cause dementia. I'm not going to read all of this. You have your PDF, and we have a lot to cover, or your slides. So, but we have a poll in a moment about how do you guys counsel your patients about smoking? Do you use this 1-800-QUIT-NOW or the CDC Quit line, which has been ongoing for 15 years? The recommendations are, of course, if you're to quit smoking, it's through public education, through price control, through prevention of smoking in public spaces, and to this to accessibility to smoking cessation advice and support, medication, and so forth. So what methods have been effective in your clinic for smoking cessation in your patients? And what resources do you guys use? I'm just really, and you can unmute yourself if you want. I can stop the share and we can, or you can put it in the chat, whatever you'd like. Please answer.
Nancy, it's Carrie. How are you?
Hey, Carrie.
Can you hear me okay? Yeah.
Yeah, we hear you great.
So we do a lot of combination of things like behavioral health support like CBT and then pharmacotherapy. So nicotine patches and varenicline and bupropion and really
Mhm.
emphasizing the multimodality type of
Yeah.
treatment.
Yeah. Thank you. Anybody else want to share what's worked well with them? for
Donna
smoking
put in the
cessation?
chat the 1-800-QUIT NOW line.
Yeah.
So that's another resource that's being utilized.
Great, great. Yeah, Carrie, and emphasizing that multimodal approach, CBTI, along with medications. Anybody else before we continue? Okay. All right. So we'll move on. So there are so many organ systems that are affected that can contribute to brain health challenges. And there's this growing evidence that subclinical dysfunction of the liver, the heart, the gut can be associated with age-related cognitive decline and dementia. And this is just a great paper that came out just this past year. And different effects relate to from organ dysfunction to brain dysfunction include, systemic endothelial dysfunction, reduced peripheral clearance of waste, such as these misfolded proteins, amyloid and tau, systemic inflammation and neuroinflammation, and alterations in the microbiome. In America, 6 out of 10 adults have a single chronic disease and 4 out of 10 have 2 or more. You see the top chronic diseases, and this is a leading cause of death and disability, with this over $3.3 trillion in annual healthcare costs. And the key lifestyle risks for chronic disease are here: tobacco use, which we've been talking about, poor nutrition, lack of physical activity, and excessive alcohol use. So it's a huge challenge. So shifting to diabetes. Diabetes is associated with anywhere between a 1.5 to 2.5-fold increase in risk for dementia among community dwelling elders. And diabetes is a risk factor both for vascular dementia and Alzheimer's disease, mixed dementia. And here are some of the mechanisms by which diabetes may cause dementia. So increased microvascular disease, atherosclerosis, the toxicity of the glucose, and central insulin resistance. How many of you use the YMCA diabetes prevention program? And has it been helpful with your patients? I'm curious. You can unmute yourself or just put it in the chat. Or other programs that have worked well for you in the treatment of type 2 diabetes. Okay, so we'll continue. We know that obesity also increases the risk of dementia. It can reduce blood supply to the brain. It can increase neuroinflammation, and of course is associated with a significantly increased risk of type 2 diabetes. We know that midlife obesity increases dementia risk. However, we also know that physical frailty increases risk of cognitive frailty and dementia. And actually, as people get older, they tend to be healthier with more weight. They're less frail. So it's really midlife obesity that we're primarily talking about. Okay, and the standard American diet, as we all know, is typically very high sugar, high fat, which contributes to inflammatory states, which increase incidence both of obesity, diabetes. We crave sugar. It's just kind of a vicious cycle. This review came out a couple of years ago looking at a potential modifiable pathway linking obesity, Alzheimer's disease, and depression, all of which have pathophysiology associated with chronic neuroinflammation. And as I'm emphasizing, really this life course model midlife interventions are key for dementia prevention. And, you know, in the discussion, chronic inflammation serves as a key mechanism linking obesity, Alzheimer's disease, and depression, encompassing systemic inflammation from metabolic disturbances, immune dysregulation through the gut microbiome, and direct interactions with amyloid pathology and neuroinflammation. So I thought I would talk for a moment about these new miracle drugs that are expensive and underutilized and also pose challenges. So these are the GLP-1 drugs. And as you see here, I just kind of grabbed, I mean, semaglutide and cardiovascular outcomes in obesity without diabetes. So benefits for cardiovascular health, benefits for treatment of obstructive sleep apnea, benefits in chronic kidney disease, benefits in fatty liver disease, really having a significant impact. There was also just this week a study that found that once weekly semaglutide helped people with alcohol use disorder. And this was a randomized clinical trial. It was a phase 2 double-blind parallel arm trial. They used low dose semaglutide and it reduced the, amount of alcohol consumed during a post-treatment event. So they drank significantly less, and these were folks with alcohol use disorder. So there was a significant treatment by time interaction, which indicated that semaglutide treatment predicted greater reductions. Oh, no, sorry, this is a different study. I don't know how, but of alcohol use. Okay, so what are some key takeaways? So the GLP-1s, they effectively promote weight loss and reduce the risk of cardiovascular disease and other diseases. However, there's major challenges. There's GI side effects. We know that if we stop them, there's weight regain after cessation. And also people lose lean muscle mass. So there's sarcopenia risks. We need to think about the use of the GLP-1s along with lifestyle approaches. So to combine the GLP-1s with dietary changes and physical activity that can help reduce the side effects, smaller portions. It can also enhance the efficacy and optimize metabolic health by maintaining that lean muscle mass. We know that dietary approaches such as the PrediMed Plus trial or Mediterranean diet and physical activity can reduce abdominal fat and preserve muscle mass. So these combinations really are probably most effective. So this powerful combining these effects of GLP-1s to reduce cardiovascular disease and lifestyle approaches like teaching kitchens or using our partners in nutrition science to help people to learn how to cook and eat and enjoy food in a different way. Also, access is, of course, crucial. These are a lot of, they're very costly, and folks don't have nutrition counseling necessarily. That's limited. So we've got to look in the future more holistically with real world data on the combined effects of the GLP-1s and lifestyle factors. So how do you integrate these across healthcare? Okay, so what about GLP-1s and Alzheimer's disease? So in a systematic review that came out last year of GLP-1 receptor agonists in Alzheimer's, there was no benefit found. However, this EVOKE and EVOKE Plus study, which as you see are 2 large-scale double-blind placebo-controlled phase 3 trials, it's going to read out in September, evaluating the efficacy, safety, and tolerability of semaglutide in early stage symptomatic Alzheimer's disease. So this is coming down the pike. So what methods and interventions have been effective in reducing obesity in your practice? And you can unmute yourself, or we can all acknowledge that this isn't really hard. I mean, these chronic diseases to support people for behavior change is really, really challenging. It's a team sport for sure. Do you guys have health coaches? Do you use the Y referrals? What is? something that, if anything, you might want to share with us? Acknowledging it's incredibly difficult. Okay, so we'll go on to LDL cholesterol. So this was a huge, over 1.8 million people over 2 decades, a retrospective cohort study. And from over 1 million folks age 40 in 1992. And there's a modest positive association between midlife LDL cholesterol and dementia. The better your LDL is controlled, the lower your risk. There are weaker associations for total cholesterol and dementia. And this association is more pronounced in midlife, and the associations are weaker in elders compared to folks younger than 65. We know that depression, chronic depression, is an under-recognized target for the prevention of dementia in Alzheimer's disease. And there was a meta-analysis that had over 66,000 individuals, and there was an increased risk associated with depression that didn't differ by type of dementia. And you see here range from 83 to 104% for diagnostic thresholds consistent with major depression. So I'm emphasizing here really that the risk is associated with continuous depression symptomatology. I mean, depression is extremely common. An episode of depression, probably 1 in 4 people, between 20 to 25%, really, or maybe higher in some age groups, certainly. And we know that also untreated late life depression is consistently and similarly associated with twofold increased risk of dementia. So this randomized controlled trial came out just last month. It was a multi-site study looking at cognitive remediation and transcranial direct current stimulation in folks who had major depressive disorder. Not an acute episode, but had a history of major depressive disorder. It was in remission. And what they found was that cognitive remediation and transcranial direct current stimulation showed cognitive decline in older adults with remitted major depressive disorder and mild cognitive impairment. So this is a promising result, I would say. The results were seen, they were more beneficial in people who did not have the ApoE4 susceptibility risk. So I just share this. I think it's promising. So what about traumatic brain injury? Multiple national cohort studies have shown that TBI, even in mild instances, may be a significant risk factor for developing dementia. So there was a huge Taiwanese cohort study where the incidence rate of dementia was 6-fold for people who had a history of TBI. In a Swedish cohort, there was a dose dependent risk, meaning the more traumatic brain injury, the higher their risk. However, we don't, the definition of, and we used to think of multiple concussions as increasing not only your risk of dementia, but in particular your risk of chronic traumatic encephalopathy. And in this study, they looked at chronic traumatic encephalopathy, really with detailed clinical history, neurocognitive assessment, physical examination, et cetera, to identify these distinguishing features and treatable symptoms. And we used to think that if people who had a history of multiple concussions presented at a younger age, they were likely to have more neuropsychiatric, more kind of an FTD picture, neuropsychiatric or behavioral issues, and later look more Alzheimer's with more sort of cognitive issues. There's ongoing research that has better characterization, I would say, of these people to kind of come up with accepted criteria. And then, what about fluid biomarkers? Fluid biomarkers are blood-based biomarkers for dementia or for chronic traumatic brain injury. And I would say we're not yet there for either, frankly. This is neurofilament light, but also it's the NFL or the National Football League. These are some of the blood, the fluid biomarkers. So NFL, glial fibrillary protein, and tau. And these are measures of axonal injury, astrogliosis, and tau and amyloid deposition. So there's really no validated objective biomarkers for TBI or concussion, and it's based on assessments and symptoms. I would say in the VA, there's a ongoing study too around blast injury. So it may not have to be impact, but actually blast exposure and increasing your risk of cognitive decline. That's an area of research. So what about hearing loss? We know that hearing loss is associated with dementia and cognitive decline. And in this randomized controlled trial called ACHIEVE, which was a multi-center study in 2023, there was a benefit for identifying and treating hearing loss with hearing aids for those who were at risk for cognitive decline. So that's emphasizing the importance of identifying any perceptual processing abnormality and really treating it. So evaluating for hearing loss and treating it with either hearing aids or pocket talkers, or and possibly sometimes even different therapies. And what about vision loss? Well, there's, we've known that vision loss, such as macular degeneration, is associated with an increased risk of Alzheimer's. Multiple longitudinal studies have found this. What about alcohol? So this is an area of really, I would say, a lot of contradictory in some ways, or difficult to kind of mired research, let's say. So an overview of a systematic study conducted in 2017 found that people who had more than 14 units a week had an increase. But if people had less than a glass per day, which is about 12 grams, that's about a glass of, say, a glass of wine or a pint of beer or one drink, there was not an increased risk of dementia. These are observational studies, so they're flawed in that regard, and it's not a one-size-fits-all. And of course, if you have a history of alcoholism in your family or for other reasons, and of course, we do also know that alcohol is associated with an increased risk of multiple cancers as well. Yeah, Kristen, you have a question?
Sorry, that was an accidental push.
Oh, that's okay. 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 So then, this is a lot of information. It's kind of overwhelming. And how can we take a pause and say, if we are not living in our lives trying to incorporate some of these positive health behaviors and practices and use tools and programs and communities and support, it's very hard to effectively support our patients and their families. So I'll just talk briefly about some stress management approaches and how that can impact cognition and brain health. And this is an old study by Rebecca Wells now, but and I'll talk broadly about mind-body practices. When I say mind-body practice, I mean kind of mindfulness or meditation, yoga, qigong, tai chi, can be forest bathing, whatever some people have, whatever sort of cultivates attention, breath awareness, slowing down. But in this case, in her study where they had a meditation practice, over time, it slowed the rate of hippocampal volume atrophy in those who had actually MCI. It was a small study, I grant you, but it was a randomized control trial. And then another study by Hans Luters, again, this is a while back, but found that people who had a contemplative practice for some time had larger brains. So, in our distractible 21st century, what I hear in the clinic is people have a really hard time concentrating. And when they describe that they have memory loss, often it's like they say they went from one room to the next and forgot what they were looking for, which is really sort of an attentional challenge. So people are very, very distracted in this fast-paced, multitasking world. So I would say that for our cognitive health, if we can slow down and think about intentionally, shifting our attention to our breath or our body, these practices can be really useful and helpful. And we've spoken about some other, different apps that have been used or different approaches that people may have. Okay, what about food? So the MIND diet is the diet which has been studied most extensively for people with, to prevent dementia. And it's really includes primarily plants, especially leafy greens, rich in vitamins, minerals, antioxidants, fiber, really good for brain health, heart health, gut health. And an initial study found that adherents who adhered very high to this diet had cut their risk of Alzheimer's by half. Now, I presented previously to this ECHO community a randomized controlled trial comparing the MIND diet to dietary counseling, which didn't find an effect. But I would say looking at all the studies on balance, eating a more plant-based diet, rich in a diet to diversify the gut and microbiome can be really healthy. Also including healthy fats with polyphenols, regular consumption of berries, which are rich in, of course, antioxidants, the anthocyanins in the blueberries, these flavonoids that are associated with improved cognitive function. Also adding in the whole grains like oats that can bring down your cholesterol, brown rice, whole grains, whole wheat bread, great fiber, healthy fats, as we talked about, like olive oil and the nuts or avocado. And whereas the MIND diet has been studied most extensively, there are many heritage diets. And when people eat, they really are eating with, their senses, they're eating with their family traditions, they're eating with their cultural heritage. So there are many ways to get healthy pyramids of healthy diets, as you see here, in a variety of heritage and traditional diets. When we think about the plate, we ideally want to have half the plate with these non-starchy leafy vegetables, and then about a quarter with protein, tofu, beans, and then some whole grains. Love our berries and nuts, and then really limiting the red meats, especially the processed red meats, sweets, fried foods, and full fat dairy. So this just came out this past week, and they were looking, epigenetic clocks or DNA methylation clocks are measures of biological aging. And it was kind of an interesting study where it was a post hoc analysis of almost 800 trial participants, and they had vitamin D, which we all need up in this Seattle where we don't get enough light. We certainly should be taking our vitamin D, but they took vitamin D and omega-3s. And the people who took omega-3s had slower rates of aging over 3 years. It was a small protective effect, but they had slower rates of aging on the 3 epigenetic clocks that were looked at. It was about 3 to 4 months. And then vitamin D supplementation, when combined with omega-3 and home exercise, that synergy showed an impact on one biological clock measure. I just throw this up because we do need to think about alternate protein sources when we're thinking about personal and planetary health. And there's a reference, and you can take a look. And then this study was developed actually to look at cocoa supplementation. It came out, I think, last year. But what they found was actually in elders, MV, a multivitamin, improved global cognition and episodic memory. So the cocoa that people were taking, cocoa supplementation, didn't help, but in fact, the Centrum Silver did. So typically we recommend that people get as much of their micronutrients and food in whole foods, but Centrum Silver may be beneficial, as demonstrated here in this study, in our elderly population. Okay. So as Michael Pollan says, eat food, not too much, mostly plants, and then as best one can, mostly home cooked. But we need to, when we have these discussions, we be very sort of culturally humble and talk about needs and preferences. Who's the grocery shopper? How do they walk around the aisles and not get sucked into all of the super sweetened, super salty bits that look so yummy? You know, how do we make incremental changes? How do we add in? How do we think about body composition rather than that number on the scale? What's the harm reduction model? You know, and as I said, I mean, eating is a pleasurable thing, right? We don't eat it if it's not delicious. So thinking about and encouraging folks. I wish I could write a prescription for culinary therapy like I can write a prescription for physical therapy, occupational therapy, speech therapy. I wish I could also write a prescription for outdoor therapy, but really that culinary therapy, because most people, the art of cooking has really been lost, which is a tragedy. And we need to find ways to support people to learn how to cook delicious home cooked meals that are nutritious. There was just something actually at UW. I just have the link here through the Osher Center about diet, which you can watch if you're more interested. This is an event, a pop-up teaching kitchen event that we did. We're part of the Teaching Kitchen Collaborative, and we did this at the Memory Hub. We cooked we got herbs from the garden at the Memory Hub, and then we cooked with folks here, and we ate together and sat around the table. It was just a lovely event. So what are resources in your community or practice that have helped improve nutrition or nutrition access? I mean, another thing is that, you know, we have these, there's a lot of food insecurity and nutrition insecurity, and it's growing in elders. So what are some resources that people have used? Some programs, senior centers, food banks, that type of thing.
I'm seeing Karen Hayes has her hand up.
Okay.
Yeah, hi. Speaking as a caregiver, in 2018, I learned about the Bredesen diet, which is very, very low inflammatory and
Mhm.
low glycemic, et cetera. Anyway, so at that point, my husband was kind of early moderate dementia, and I said, hey, let's just try this. Why not? We don't need a doctor to order this. Let's just do it. So we completely upended the diet. My husband didn't have obesity or anything, but high carb, high sugar diet for decades. And so we just went cold turkey and did it. And within 2 months, I saw improvement, demonstrable improvement. His sense of humor came back. He was able to have more complex conversations with me, could then use the remote again. And so we both, he felt better. And so
Thank you for sharing that. Yeah.
Yeah, his sister went on the diet and she said her ADHD got better. Anyway,
yeah.
The point I wanted to make was, you know, it's a pretty strict diet.
Yeah.
I was motivated and he was motivated to adhere to it strictly. But it was 5 years of social challenge, friends and going even dementia-centered potlucks and so forth, where the food on the table, we were just like, oh my God, we can't eat any of this stuff.
Yeah.
And people turning to me as the caregiver, implying or saying outrightly that I was depriving him. Oh, he has dementia. He should get to eat whatever he wants. If he just wants to eat candy and cake, he should get to do that because he's sick and this is, you know, terminal disease and blah, blah, blah. And a few people, I mean, I had to do my own advocacy for it. And a few people then kind of got on board and when we went to their house, they would cook things that were appropriate for us and they'd check in with me and stuff. But I'd say 80% of the people, I think, thought I was depriving him and that we were. Once you get on one of those diets, within 6 months to a year, you don't feel deprived. You look back at
so thank you so much
the
for sharing
habit.
that, because I mean, I think what you're sharing is, you know, we know that for diets, there's not going to be a one size fits all. I mean, what I would say in terms of like where we are with, I'm just going to bring this up again, you know, is if we can have mainly whole foods, if we can have fruits and vegetables, nuts and seeds, spices and herbs, and beans and greens, it's anti-inflammatory, as you say, it's antioxidant. And then in thinking about how, how we can continue to socialize as well, because as you say, if we're in really strict, it can be really hard. So I appreciate that too.
Yeah, and if care
There-
providers, like with smoking and with alcohol,
Yeah,
treat nutrition the same way and help the patients come up with ways to advocate for themselves and control their intake and maybe find
Yeah.
different friends, whatever it
Yes.
takes. But just doing some of that kind of support for people
Yes,
to not, quote, cave
right.
back to bad habits that all their friends are still doing.
Because you're doing the cooking and you're creating the environment that he's eating in, and then how do you, right,
How do
weigh,
we help people being in a
yeah,
non-smoking environment or a non-alcohol
right.
environment,
Thank you.
or to
No,
stand up for themselves in a
right.
friendly and not lose your friends, but
And Angela Hansen also gave a talk at our Echo, and we can put that in the email too, as people, as they're, as people's cognitive health challenges change, their eating patterns may change, and the benefit also of healthy diet changes too. So it's a very challenging topic, as it's we have to kind of frame it at different phases. I think for primary dementia prevention, there's ample evidence that this type of diet can be helpful, and then as things progress, perhaps the impact, the return on that maybe diminishes.
I'll also
Um,
direct everyone to the chat. Carrie Rubenstein put in a great link for Lifelong. They have options for medically tailored diets for low-income people, specifically in King, Snohomish, and I believe it's Island counties.
Thank you. Thank you. And then the Chicken Soup Brigade. Or that's what you're saying, to the Chicken Soup Brigade. All right, so shifting to sleep. So we know that, untreated sleep apnea can increase your risk of dementia. And so how would we identify that? Of course, we've had amazing talks by Lena Fine, but somebody who has daytime somnolence or frequent loud snoring, gasping for air. We want to identify and treat sleep apnea. Restless leg syndrome can interfere with really good restful sleep. This may be perceived as like burning or creepy crawly sensation or itching. And then REM behavior sleep disorder is when the normal sleep paralysis doesn't happen, and so people act out their dreams or they shout out their dreams. And this behavioral disorder, this REM behavioral sleep disorder, is associated with increased risk of neurodegenerative disease, and in particular Parkinson's disease or Parkinson's and Lewy body. We know that insomnia, chronic insomnia, which is so common, is associated with an increased risk of dementia. Chronic, as I say, chronic insomnia. And the best, most effective treatment by far is cognitive behavioral therapy for insomnia. And there's a great app from the VA that's free. We can also share that out. But and then some sleep doctors, and in our clinic, Emma Dodson actually is trained in cognitive behavioral therapy for insomnia, so she offers that. We'll be offering that this year to our patients. So, what's the mechanism? Well, sleep deprivation increases the neurodegenerative misfolded proteins that can aggregate the tau and the amyloid. Restorative sleep allows us to clear those toxins and waste products that can otherwise interfere with neuronal function, that are, the hallmarks of neurodegeneration. It also helps us to consolidate memories, to problem solve, to think creatively. And if we know that there's circadian disruption in dementia, and lack of sleep can intensify agitation. It can also increase our fall risk, promote physical, delay healing. So huge. I'm going to kind of speed up here. We've seen this slide before, but exercise is so important. We know that we release these, hormones, these exokines that affect multiple organ systems to promote health and reduce cardiometabolic disease. Yes, and these are the ways in which your brain loves the gym. So in people who have Alzheimer's disease, exercise is associated with prolonged survival. There's been so many meta-analysis, over 90 meta-analysis in the last 5 years. The benefit in terms of cognition is primarily for processing speed and executive function over memory. It's been very hard in a lot of these studies to demonstrate benefits in memory, but in order for us to function independently in the world, what we also rely upon is our frontal lobes and systems and environment and community. So processing speed and executive function are really key as well. And if you look at these pooled effects in this meta-analysis, that's most robust for delaying the onset. So that primary dementia prevention upstream, there's evidence in MCI and less strong evidence in dementia. It is more beneficial in a group than in an individual for most people. But again, everybody's a little different. So some people may prefer putting on music and dancing in their home. And it's beneficial across multiple settings, including home-based and different apps. What's recommended by the American Sports Medicine is at least 150 minutes of moderate aerobic activity or 75 of vigorous activity, 30 minutes, 5 days a week. Strength training 2 to 3 times a week, but twice a week. And then balance training 3 times a week, which can be Tai Chi, yoga, working with a trainer. Air pollution, I'm going to go through this actually kind of quickly, but air pollution is a risk, and it's particulate matter, and the smog, basically. So if we adhere to about 5 low-risk lifestyle factors, that is associated with a 70% lower mortality and could extend life expectancy at 50 by 10 years. And these are the 5 risk factors, lifestyle-related factors that we've been talking about. So they have an impact on dementia risk, but also on health span. We talked a bit about cognitive reserve. Formal education has some of the most consistent and strongest evidence as a protective factor. Fewer years of formal education is associated also with lower socioeconomic status, lower education levels, are associated with less physical activity, more diabetes, more hypertension. These are complex relationships, and lifelong learning, as we know, is really neuroprotective. This is a big meta-analysis looking at a lot of randomized controlled trials of cognitive stimulation, and on balance, there was a benefit for cognitively stimulating activities in people with mild to moderate dementia. So lifelong learning at all stages and ages. Social isolation can be lethal, as Vivek Murthy has really eloquently written about, and togetherness and spoken about. But in this study from Rush, and this memory and aging cohort, over almost 2,000 elders were followed for almost 7 years, and the higher social activity resulted in a 5-year delay in dementia onset. So I'm going to kind of skip over this, but really it can act in multiple different ways. I think I'm going to kind of get to questions because I want us to have a conversation here. So I'm going to skip here and simply mention that this study just came out. This is shifting a bit, but talking about sex-specific benefits for monoclonal antibody therapy. And this paper found higher benefit of lecanemab in males compared to females in the Clarity AD. And there was a simulation analysis, a rigorous biostatistical analysis using the Alzheimer's disease neuroimaging data set, as I understood reading the paper. And what was found was that lecanemab is less likely effective in females than males. So we need to pay attention to that and think about sex-specific benefits. I think I'm going to just say briefly that at our Center for Healthy Aging, we have an 8-month series of shared medical appointments where we, in this community of learners, such as our community, but with patients and families, have a brief didactic, learn about these health behaviors, and then make sort of through motivational interviewing, create these goals that we work on over the course of 8 months together. Okay, thank you for your time. in examining these modifiable risk factors, what are your thoughts? What risk factors have you had? You know, what are super challenging? What are successful? Let's share the successes. What resources exist in your practices and communities? Because you guys are a wealth of resources as well. There's our references here, but I'm going to stop the share. And before I call on Karen Clay to share her wealth of information, I'd like to hear from others in the community, you know, about one thing, just like one thing that you use in the office that has been helpful or useful to you in talking to your patients about risk reduction, approaches to dementia prevention. Do you want to put it in the chat? Okay, Karen, I'm going to call on you in one moment, but I just want to hear from, was there any pressing question? Or things that are surprising? Karen, do you want to share from your perspective some other resources, please, Karen Clay?
Sure, I'm happy to. One of the things that I would say is that we're finally getting back to where we were back in 2019 before COVID hit in terms of activities that are happening in the community. There's now memory cafes throughout the state of Washington. There's one in Spokane. There's one in Tacoma. There's several King County, including Greenwood, the Memory Hub, Bellevue. There's one in the Bothell area. I think there's a lot more too. So those types of things are coming back. The good places to find out about what's happening in your area in the kind of Seattle, especially Puget Sound area, that great resource, the momentiaseattle.org, one-stop shopping for like what's near me that is memory or dementia friendly. And they've got zoo walks, they've got memory cafes, improv theater, more art type programs that are happening. And then outside of this area, really the area agencies on aging is like, again, one-stop shopping for like what is happening near me. And I would say too, like in particular, outside the Seattle area, the people that you contact there know their area, they know the people that are doing the work there. And so they really are able to say, like, yeah, we've got these early stage memory loss programs. We've got these just general wellness programs, activities that are happening together. And so by just knowing one phone number or one website, you should be able to contact people to these things that are like up and running again.
Thank you. That's so helpful. So helpful. Anybody else want to share some resources or?
This is Karen Hayes. I'll just talk again about caregiver and the person with dementia. And, I'm in urban Seattle. There's tons of resources, which is really great. Although a lot of our dementia journey was during COVID, so everything was shut down, but made me appreciate them even more. But I'd say what I saw with my husband and a lot of my caregiver friends who are caring for spouses or parents with dementia is I think people need more tools for how to overcome resistance to go to these things. You know, there's the early months or years of dementia when it's, you know, MCI turning into early dementia, where there can be a lot of denial or avoidance, or I don't want my identity to be associated with this, or they go to one of these things and everybody's more advanced than they are and it scares them, or they just don't feel like they belong. But if you wait too long, then their ability to adjust and get used to everybody and get into the habit of going to this place every Tuesday afternoon or whatever it is, you start losing that when they get further on in dementia and get resistant or can't participate in a meaningful way. So I think caregivers and people with dementia need more assistance from care providers and social workers and other people on how to frame it in a way that gets them to go to these things.
Thank you. I think we'll be hearing and seeing more about semaglutide and the other GLP-1s. That's a big topic. I don't know if anybody wants to share about that in the last couple moments. And if not, then I will just remind us that please just text this 10085 to this number if you're registered for SAMI credit, or reach out to SAMI. Next session is with Susan McCurry, an enhanced perspective for understanding and responding to appropriate behaviors. Then we're very fortunate on March 7th to have Dr. Sylvia Russo, who's going to talk about at the Dementia Innovation Summit what makes a good primary care referral from a neurologist perspective. Thank you, Sylvia. And then Karen Hayes is next on the 14th with aggressive behavior and violence in dementia, caregiver and law enforcement perspectives. And then Carrie Rubenstein on age-friendly delirium prevention and delirium in outpatient settings. So stay tuned. Please join for those. As I said, this is our next session. Please complete the 1-minute post-session survey. And I think we are just about at time. Thank you. Happy Valentine's Day, everybody. Nice to see you, Kelly.